Hello and welcome everybody to Co-Produce Care's live stream. Today I'm absolutely delighted to have a fantastic guest with us. James Bullion. If you don't know about him, you should do, and by the end of this live stream you will do. So James is the interim chief inspector of adult social care at the moment, and he's been stepping up, leading the inspection teams across the country for adult social care, and we are delighted to have him with us today, and he will be answering your questions. Now, I'm really so happy that so many of you got involved. So we had over 300 questions that people were asking us about I know what we wanted to put your questions to James directly. So we've just sifted through those 300 questions, and we have tried to put as many as possible in groups. We've tried to use your exact words as you have asked the question to him. So I'm really excited to see what the answers are. I have no idea what the answers are. So stay tuned and you'll find out all of that. So just as a little bit of an intro, I will say sorry because I have got this 100-day cold that seems to be going around in December 2023. So I'll try not to snivel through it. But we have some really fantastic things coming up. And this is totally pro bono. We just do this because we feel like this is useful for the sector. And all we would ask for is that you give us a thumbs up. So wherever you're watching, whether it's YouTube or whether it's Facebook, give us a thumbs up. Let us know this is roughly what you want to be hearing. If it's something else, then put it in the chat. Just to give you a little bit of a heads up of the other things that we will be doing in the new year, we are going to be looking at the outstanding CQC report. So what I've been doing over the last quarter is just looking through the outstanding CQC reports for social care, specifically care homes that seem to be getting outstanding. I couldn't see any supported living that was getting outstanding in the last 3 months, but summarizing them. A bit of a snapshot, summarizing them in the themes that the Chloe's, the key lines of inquiry. And if you are a member of Co-Produce Care, absolutely free to become a member. You just have to go onto our website and ask to become a member, sign up, and we email those out every quarter once I've had a moment to do those. But next year, in February, early February, I'll be going through them on a live stream just like this, and hopefully have a few guests as well to talk through the themes. Obviously, being outstanding is not a checklist, but some of the ideas, even if it's not just to help your own service become outstanding, it also helps to inspire some thought about how we can do things slightly differently, and how other organizations have managed to, whether it's work with the community or work with other organizations or dealt with some of the barriers. And of course, some of it will just seem quite basic. So that's in February. And of course, if you are signed up to our newsletter, you'll be able to get an email of how to join that. And if you're not, then what are you waiting for? Okay, so we have James joining us. I'm just going to crack on, actually. I'm not going to do a huge intro because we have got lots of questions, not the 300 that were originally given to us, but we have lots of questions, and I do want to get through as many as possible. So I'm just going to bring James into the stream. And do say hello in the chat. Tell us where you're coming from, what you think of what's being said. That interaction is really golden. And like, please, so we know what we're doing is the right thing for the sector. Okay, so welcome, James. Thank you so much for joining. I know you're super busy.
Hello, hi. No, delighted to be here. Thanks very much for having me.
Welcome. You're very, very welcome. And I have to say a big, huge shout out to CQC for interacting with the sector like this, and answering our questions directly. It's just a wonderful thing to have you on here. So thank you so much. I am not going to do too many intros. We're going to get straight into it because, as you would have seen, we have quite a few questions to get through in an hour. So we'll do our best. But if I might just indulge in a bit of tomfoolery, I might just warm up by asking you a silly but maybe interesting question. So recently in I'm a Celebrity, which is just finished, the contestants won a trial and were able to have crumpets as a treat. Now, I myself, a big fan of crumpets this time of year, but assuming that you like crumpets, what would you have on your crumpet, James?
Oh, I don't know. I mean, I'm not supposed to eat crumpets, but I do like a crumpet as well. So the best for me is Marmite. A little bit of vegetable spread and Marmite. Can't beat it really. Lovely warm crumpet with Marmite on it. Delightful.
Interesting. Okay, very interesting. Thank you so much. I wouldn't necessarily go for Marmite myself, but people let us know in the chat. Does that warm you up to James, or do you think that is just despicable? Let's see. But thank you for sort of giving that answer of my silliness there. But for some people who might not know anything about you, so some people have asked this question, so it would be good to use this as an introductory one for you. What care experience have you had personally, and do you truly understand the pressures from frontline staff?
Yeah, so I've been working at CQC for about 6 months. Before that, I've been in local government for about 30 years, actually, mainly in social care or community work. I'm a community worker by background. So I grew up in South London on the estates around Lewisham and Deptford, did a lot of work on housing and debt and working with families on those kind of issues. But growing up, actually, I do have a couple of caring experiences. One, I am a family carer for my sister, Jackie. My sister she has a learning disability, lives with a learning disability. So I actually help her manage her personal budget at the moment. She's with a different local authority. And all growing up, actually, I was, you don't really think of it in these terms, do you, as sort of young carer or family carer? She's just my sister. But I've got that experience, which really enriched me, actually. And it does bring the reality to you, even now as I work, alongside her, supporting her to do that. And I've also been a carer to my mother, who had dementia, died in the pandemic year as well. So I've got a mixture really of lived experience and professional experience that I draw on. Although I don't use my lived experience even for anecdotes really most of the time, because I think it can be really misunderstood.
I really appreciate that you shared that with us, and sorry to hear about your mother. But it is really refreshing to hear that you've had experience at so many different levels. Actually, that's really interesting to know. So thank you for sharing. So we've split this up into different themes, and one of the first themes that we've had is around local authorities. So what is being done in terms of the regulatory framework around local councils whose unresponsiveness creates poor outcomes for service users? Now, I have just quoted that question as it came into it, so feel free to put your interpretation of what that might mean and answer as best you can.
Yeah, so we CQC now have got the job and we've just got permission to roll out the job of assuring adult social care in local authorities. First time that's been done for, I think, 12, 13 years. I can remember being on the receiving end of that, backing a local authority back when I was in Suffolk, actually, at that time. So we've got that task now of looking at how the Care Act has been implemented in councils, and that includes using some quality statements that CQC have to judge how well things are being done. And those quality statements are on our website if anyone wants to read them. They're really built from the I and we statements from Think Local, Act Personal. So it's a look at what people are experiencing and how well the Care Act is being implemented on behalf of government. And following the pilots that we did with 5 councils, we'll publish a report on each council, which will give not only an overall rating, but a score, because it's never as simple as one word, is it? We know that. But underneath that, there'll be scores against the areas of work that we've been looking at. And we've been using 9 of our quality statements, goes right across the piece from how it's led, what's the impact on people, what are the partners saying, what's the community saying. So it gives CQC an opportunity to comment on what we find with councils, but it also gives us evidence to report back to government, which you might well know, we have an annual document called the State of Care that we publish every October. This process will give us evidence to independently placed before Parliament, which is what that report is, what we find. So, you know, where we find good, we'll praise the good. Where we find things that aren't responsive, we'll point that out. And it's up to councils then to respond and improve and change. We don't have the job of overseeing their improvement. That's done by others, but we have the job of finding what we find and then pointing it out.
Great. So in other words, you don't necessarily are not able to change what they do, but you are able to point out where there is unresponsiveness, as this question suggests, or any other issues with quality. Okay, thank you. That's really helpful. Another question on local authorities. 4 out of 5 pilot local authorities were provisionally rated good. What does it take to be outstanding? This is for local authorities specifically.
Yeah, well, we publish a handbook actually on the website, which takes you through what we look at and the scoring. So the scoring runs from 1 to 4. 4's outstanding, 1 is inadequate. So you can see in there actually what we're looking at and the kind of descriptors or indicators of what good looks like and what, you know, requires improvement look like. So to be outstanding, you really, you know, to state the obvious, first of all, you've got to be meeting the responsibilities of the Care Act and making sure that needs are being met and things are being done well in a kind of process terms. But I suppose if you were looking at outstanding, you would be looking beyond that into really good practice, co-produced with people probably, and you'd be demonstrating changes in outcomes. And I suppose, particularly if you think about it, the job of social care is to respond to individual needs. But where you're being particularly outstanding at it, you'd be doing that. Plus, you'd be taking perhaps a more preventative approach, and then maybe you'd be taking an area-based approach to try and widen the impact on not just the people you're serving now, but the people you might be serving in the future. So it's hard to give an answer because it's so specific around the area you're looking at. But it's that kind of thing, going beyond the minimum, doing something that is good practice or innovative, and then having an impact in an area. And we hope as we go through to publish those, what's good and what's not so good in each individual report, but then pull together a report on what we find more generally with that good practice in it. And that'll make it easier to see, I think, what's outstanding.
Great. And I think that's really helpful because there isn't necessarily a checklist. It's really personalized to what's going on in the single area and the effects that it's having on the population that's being served in that area. But also, if you're able to share that good practice, it's something for local authorities to work towards and, you know, people in local areas to really judge their local authority by. So very helpful. Thank you. So before we move on to the new regulatory system, there were quite a few questions about the I statement. So I thought it might be useful just to bring up a question about the I statements. So people would like a quick introduction to what the statements are and how they will be used. Obviously, we're not going to go through every single one of them, but just a general idea of what they are and how they're being used.
Yeah, and there are 32 of them, or 34 of them actually. So yeah, can't go through them all. I suppose just to begin with the principle though, that our assessment framework, the single assessment framework, is meant to be focused on what matters to people. So it's obviously based underneath all of that on regulations, and those are set down by law. But when you interpret that about how well are the regulations being met, we try to begin with, well, what matters to people? How do people's experiences come through in the way that we assess and that and through what people say about what is going on. So that's where the statements really began. They began as a way of us trying to take the regulations and interpret at an I level, so I get the care and support I need for people, and at a we level for the providers that we provide care that promotes dignity and respect, for example. So they start to interpret the regulations into simple statements of what things should look like or feel like, and that's where we worked with CQC, and we were very careful. One of my colleagues puts it like this: we used sort of white gloves just to lift and shift from Think Local Act Personal into CQC, those I and we statements. So we haven't tried to change them because they're really built from what people say is most important to them. So we've not put our fingerprints on them. We've just moved them from there, put them into our framework, and that's what we use to try and interpret what people have experienced through the regulations. That's the kind of core of it, really, Sophie.
Great, really helpful, and really succinct in answering these questions. So hopefully we'll fly through quite a few of them. Thank you. So moving on to the regulatory system proper, what excites you the most about the introduction of the single assessment framework?
Well, first of all, and this is a bit kind of under the bonnet of the engine type stuff, so I apologise if I lose people in my descriptions now. But first of all, this single assessment framework unifies across health and care a single approach. And before we've developed this and started to roll this out, we've had, I think, 11 different systems of regulations and standards. Now, none of the regs have changed. The regs are still the same. The law is the law, but we've been able to read across health and care the same standard. So rather than asking something that's very bespoke and specific to, I don't know, maternity setting, and then a person in learning disability supported living, for example, we're able to apply a common standard to both and get at experience that people have got. That's the first point. So that's very exciting, that in the way that you bring the social model, if I can put it like that, of the social model of living, of say disability, into a medical setting to say, is this promoting dignity? It's not just about the standard of care or the temperature on the fridge, it's what's your experience. And that's quite revolutionary, actually, for a regulator to be able to do that. And then the second thing that's exciting is that it enables us as a regulator to look at a place. So no longer do we, let's take the example where I am, I'm in Norwich. If you look at Norwich now, you could potentially have a single framework that looks at everything in that place, whether it's a hospital, whether it's a social services department, whether it's primary care, whether it's the integrated care system as a whole. And you could apply the same standard and therefore begin to conclude, what's it like to live in Norwich if you are an older person or a younger person with a disability, or if you've got protected characteristics, what's the degree of discrimination that people are experiencing in terms of their outcomes? So that it's a sort of technical answer to this, but it's really exciting that you've got a single framework rather than there's lots of competing frameworks and you're having to translate as to, does that equal that or does that equal that? Actually, they are all the same.
Yeah, and I think it's really interesting because you talk about integration between health and social care, but it's really hard when you are regulating them and looking at the outcomes that people get in different ways. So I think, it seems like this would be the first part of quite a longer journey. So might not be instant results in like a year or 2 years, but after you've had a few more inspections and you've really understood, how those reports can be compared system against system, you can really see where, even in the out of sight reports or in the annual reports that CQC are doing around the state of the sector, you can really see where there are some gaps and needs for improvement. So yes, it does seem quite exciting, but maybe a bit more of a longer journey than instant results. So we'll see. So next question that somebody has asked is, how do you feel that the new strategy will improve care for service users?
Well, I suppose, first of all, at the core of what we do is to try and shine a light on what people's experience are for those that are drawing on care or for those patients. So the first thing is the new framework, like the old one, will help us demonstrate what the impact is on people, and that should drive improvement. We have something in our world called levers of improvements, and there are 8 of them that CQC work with, and they are things you would expect. Like, we look at the standard of something and say that's not meeting it, and we enforce against it, or we define a standard for something to be registered with us as a commission, and the minimum standard is good, so you can't be registered unless you're good. So the impact is that you have a positive impact on people because you're only registering good services. If you're not good, you can't be registered. And then thirdly, things like anticipation. So people improve services and start co-producing a view of services in anticipation that we as the commission are going to arrive and do an assurance or an inspection of their service. So the framework is still designed to bring about that kind of improvement by setting a standard, measuring against it, and whether that's a number measure or a perception measure, and then producing a result that results in action. So the core of it, the single assessment framework, like the old framework, should be doing that. But what strengthens it is those I and we statements, because probably a third of all of our scoring is now going to be based on what people say is their experience, not just on counting the outputs, so how many of people are on a waiting list, for example, but what does it feel like to be waiting for a service or to not get a service in an area. So those are quite powerful advances, really, for people who draw on services, and hopefully, as you say, Sophie, over time it will start to show areas where you need to move from where you are to somewhere better as a provider, because your results are not as good as they should be.
And it's interesting you should say, because I think providers for a while have been expecting CQC to get the opinions of people that they support for their inspections. But I wonder in the wider system how common that is. So it'd be quite nice that that aspect, although new to other parts of the health sector, for example, is now might create that equality between how views are collected. And maybe the questions are going to be slightly different as well. So that seems to be very interesting.
I mean, it's an obvious point in the way, Sophie, but social care has always had, one, a social kind of model in it, but two, it has been a market or a mixture of providers for a very long time, since 1948, really. So social care needs to sell themselves. They need to attract people to use the services. So, of course, people saying good things are used to, as it were, market services. And I think that's, on the whole, that's a positive thing, because it means nowadays, with the technology we have, it's actually easier than ever to see, both from our reports but also from websites, what people are saying about things. So I think if you release that, it creates some energy, hopefully in the right direction.
Great, thank you. This next question, I think probably a quick one. Are we still on track for the single assessment framework rollout deadline?
We are, yes, and you can find more on our website about that, but we've got government permission to roll out, and we're now in the process of doing that.
Brilliant. The next question then is there additional support to understand what the changes are going to be with I statements?
Yeah, definitely, yeah. So we've been supporting and working with providers in particular to understand how these statements translate into the evidence that we'll be asking for. So we've got sort of 6 categories or so of evidence, which includes data, as you might expect. It includes looking at files. It includes listening to partners, but also it includes what people are saying about these I and we statements. So it's our job, really, to make sure that providers feel supported about incorporating that into what they submit to us as their documentation for that evidence. And I've seen lots of evidence around the country now that providers, local authorities are working with local groups, as it were, to make sure they are good at doing that co-production and involvement of people. And that can only be a good thing. It might raise expectations. It might cause conversations that are a bit challenging, of course. That's part of the point. But hopefully, if it's done constructively, it should feel supportive. I'm very aware, though, that some people will be feeling nervous about that, because, you know, to a degree, you can't control what people say, can you? And it may not always be fair either. But it's our job as a regulator to try and get to an objective view of it.
Thank you for that. People, if you've got any comments, then please do put them in the chat wherever you are. Notice that we are streaming on Facebook and YouTube, so some places you may see questions that are being put forward that aren't actually on your screen, but do put some comments. I am going to stick to the pre-selected questions, but your comments will be still very enlightening. So a lot of the questions were about challenging CQC's decisions. So one of the questions I've sort of chosen to represent those is, how can we challenge CQC's decision if they have changed a rating without visiting the service? I'm not sure if that is possible, but hopefully you'll be able to explain.
Yes. So the process continues to be that CQC always provide a narrative report, which is shared with providers before we change a rating. But our single assessment framework means that we don't have to necessarily look at all of the quality statements to change a rating. This should be a positive. It should be about not having to have 5 areas looked at, 5 core services looked at before a rating can change, as long as we know enough pre-existing about what the levels of quality are and the levels of service are. It should allow us to come out, do a quick cross threshold for 1 or 2 issues, and then change a rating as a result of that. But it's our job to give complete and thorough consideration of issues before we go changing ratings. But they all should be on the basis of a very clear report, which we'll publish on our website as part of our new process. So people have got to worry about that. There's more you can read on the website about how we will do it. But if that's not enough, then I think make contact with us and we'll go through it in more detail for your particular circumstance.
Okay, that's really helpful to know, actually, that people can follow that up. So the next question is, how much weight will be given to feedback from partners when our partners may be too busy to provide any? So we know from experience that people who are happy with a service are less likely to reply to feedback questions than those who may. I think I just dipped out then. Did you get all the question?
I think I did, yeah. So first of all, we have to make the inspectors and the assessors have to make sure that they are getting a fair view. So if we don't get a response from a partner, we can't just go on the basis of no response and make a sort of guess at it. So we do have to be proactive, as it were, and make sure that we have some input from partners or from local organisations and try and take a holistic view about what we do get as information. I recognise what you're saying, though, Sophie, because a lot of people are content with care. I think it's satisfaction with social care is in the sort of last time I looked, it was in the 80s, I think, percentage wise. So in a sense, you've got to recognise that there might be a pre-existing level of satisfaction, which means if we do get feedback that's negative, we do have to look at that holistically and in the round to make sure we're not being, as it were, just getting a small perspective on a much larger issue. So I think if we haven't got answers from partners, we have to sort of gently and positively prod them and not just rely on 1 or 2, but a rounded picture.
And maybe it's also for people who work with those partners to give them a little bit of a nudge at their end, because presumably CQC has limited resources to be pestering people for feedback. So I suppose we all have to do a little bit of nudging. But that's really helpful. Thank you for that. We're going to go on to our next theme, which is on digital aspects of care. So the first question on that theme is, will those not digital by the March 2024 deadline suffer with bad feedback, or will the inspectors still look at their achievements?
Yeah, I don't think so. I don't think that it'll be as automatic as that. I mean, I think we said in our state of care report recently that if providers who aren't digital will find it much more difficult to sort of deal with system-wide issues that they're experiencing in their area. Whereas if you are digital, it's a lot easier to do that because you are in a system where records are shared and where they underpin the way of working. So it makes it more difficult, but we won't have any kind of automatic bad feedback. We recognise that this is a target that for some providers is a stretch. It's already inbuilt into the target for it not to be 100%, as it were, already. So in a way, we need to be realistic about that. And I think I think from my memory, I'm trying to remember now, I think it's about half of providers are digitalized already. So there is still a way to go for the other half. So we can't be that binary about it, really. Our SAF is pitched at good. Our registration is pitched at good. So we do go looking for good and expect that to be there. So if we don't have if we have a gap, as it were, in that digital record, then we have to find another way to find the answer as to is this good or not. But we won't automatically penalise because we can't find it through digital. We'll just find it another way.
Great, thank you. That's a really helpful clarification. And what is the best way we can show inspectors that communication between the office staff and community staff is to a great standard? Sometimes things aren't recorded properly when you have a great but natural rapport with staff. So I think this question was really alluding to what can you do when you just get on really well and you don't record every conversation? How do we evidence that to inspectors?
Yeah, why would you? I mean, you've got to love the fact that people's rapport can be so natural that there's no need really to, as it were. It's so usual, you don't need to write it down as unusual, if you see what I mean. So I think we've got to accept that's the case. We would try and capture that, wouldn't we, through team meetings, try and capture it through one-to-ones, or what you might find in records here and there, or compliments. So I don't think we I don't we obviously want to see wonderful feedback, but the fact that we don't have it because it's there naturally, I don't think we would try to find a special way. I suppose it's about, isn't it, when I think about our assurance methods, it's having a kind of evidence bank, or banking somewhere those standout instances of that sort of thing, an event, for example, where people have come together, or something in the paper or whatever. It's I think we all realistically have to have a bank of some things, but it doesn't have to be every day and all of that stuff. I don't think we're not looking for that.
That's really helpful to know. Thank you. So we're doing really well, dare I say, already. We've gone through a couple of themes. We're now on to inspection in general.
Yeah.
So the first question that has been submitted on that topic is, would it not be beneficial for CQC inspectors to support homes if they find faults and revisit again a few weeks after to see if the improvements have been made and then provide a rating? Everybody wants the same outcome and everyone works extremely hard.
Yeah, I mean, it's a really fair question, this. I suppose I'd categorize it into where you've got immediate concerns about something as a result of an inspection, then I would expect us to be quite timely about going back and seeing that the immediate concerns have been addressed. And I suppose there's a scale, isn't there, of that sort of thing, which relates to people's safety and safeguarding. So that you can't really set a rule for that. It's got to be bespoke to the individual circumstances, it seems to me. And then on the broader picture about should you go back quicker, I think CQC do need to make improvements about the frequency, and do need to make it clear about what the frequency expectations should be. We do have to give people enough time to improve, of course. So that's, you wouldn't want to go back sooner than you think the improvement might take place, depending on what the issue is. But neither should it be left for a long time, so that people feel that they are good now and can't, as it were, access that categorization. And I recognise that might cause issues with contracts as well, with social care commissioners too, or health commissioners. So we have got to get the timeliness thing right. The new SAF, though, as I was explaining earlier, should give us a little bit more flexibility, which means that we don't have to come back and do a whole thing. We could come back and just do one quality statement where we had a concern. And I think there's a potential as well for our system to be a little bit more interactive, and that the providers that are early adopters in our south area have told us and fed back that the factual accuracy stuff, the web-based stuff that we can now do to give each other information, is a real step up. So there's real potential here for, and this might sound like more work for providers, so I'm being cautious, but it provides an opportunity for not just us to be proactive, but providers to be proactive as well. So we've got to go at the pace we can go at. We don't want to just rush into that, because we could deluge each other with a sort of electronic system that none of us want, or some might not be capable of. But I think that way of working is probably down the line in the future. Meanwhile, we do have to get the frequency stuff clearer to providers so they know when to expect us, and we don't leave it for years and years before we come back. I know that's happened in some circumstances.
That's really helpful to hear and learn about, because I think that it just makes such an impact in terms of providers' viability. If people are not going to a home, rightly so, they might not look at it because it requires improvements, but improvements have been made. It's good to hear that maybe it might be possible to step that revisit up, or even just to let CQC know what improvements have been done on this new system. So that's good to hear. So the second question that has been submitted on this topic is, how will CQC gain feedback from those being supported in line with accessible information standards for adults with LD, learning disabilities, or an autism diagnosis?
Yeah, again, a crucial equality issue in a way, isn't it? So we, as part of access on inspection, or CQC doing sort of field work, we would have to make sure, and should make sure, face to face on site, that people who use services, or experts by experience or advocates, are able to be present and give that directly. And so we should be doing that. We should be making sure that the communications are accessible as well, to enable that to take place. There is also, I suppose, outside of that on-site approach, there is also an ability to give feedback on care at any time. And again, that's linked to the national phone system, and that give feedback on care system can then be linked to individual records of providers or geographical areas. So we try and do those two processes. But I suppose I definitely want to hear if it wasn't happening. And we work with our partners, Health Watch, who also keep an oversight with us on the fairness of the way that we do that as well. So I think we've got a couple of routes in there.
Great, that's really helpful. And if anyone in the chat wants to put some ideas of how that could be improved,
Yeah.
or just some opinions, that would be really helpful as well. And I think people can also give feedback on services online through the CQC website, which I feel is sometimes underused, which probably goes to that provider's details on the system. So that's really good. So the third question is quite long. So I think I've got so this one here is, can CQC ensure consistency in inspectors' visits, especially where care home is not registered for older people but learning disabilities? The focus and practices differ greatly. However, now, especially since the pandemic, heavily audited alongside very clinical elements of frameworks. Most LD services have at their core promoting independence, skills for life, many resources and time spent in living life. Do you believe it's necessary for people in mid-20s to have end-of-life plans, constant monitoring of BP, temps, etc.? So I think this person was quite clear, I think, what they were asking, but really, if you've got the same inspector auditing different services, which by design have to treat people differently, is the same framework or tests applicable to get the right outcomes, results in what they're trying to do?
Yeah, it's a good question, really. And the sentiment behind it really is about our inspectors need to understand the context they're in, and also the as it were, personalisation and control agenda. So I would expect in a service that's working with a person for potentially 20, 30 years of their life, you would expect different expectations around how you operate. So we definitely don't want to over medicalise that, do we? We want the person at the core of it, all of us, to be living the best life we can in that context. So us coming along and constantly checking, as it were, the medical aspects of that only, or only focusing on those features that to do with clinical standards, wouldn't be appropriate. Having said that, we do want to make sure, all of us, that people get access to healthcare, or to the stuff that we should all have a right to universally, irrespective of what our disabilities are or the features of our life. So you have to kind of find that right level between applying the same standard across the board through things like the single assessment framework, but applying it in such a way as to think about the context you're in and the period over which you're working with people. So for younger people living lives independently, you would expect a slightly different approach to, say, older people in a service that's supporting them with dementia, or home care at home for somebody the standards are the same in all three, but the approach the inspectors take should be bespoke to the setting that they're working in. Really, I think if I interpret a little bit what's behind some of the question, I think the pandemic did lead us into a sort of rather risk-averse monitoring culture, because we were so worried about people who, as it were, are vulnerable, and needed to be shielded, as it were. So, but we are no longer in that situation. We should not be shielding any of us from the sort of living the normal life. In fact, with the current conversations about visiting and access, it's rather the opposite, really, isn't it?
Yeah, absolutely. Absolutely. So this next question has been asked around overseas recruitment, which is very much a hot topic. So the person here is asking, how are the overseas recruitment sponsor modern slavery workforce issues, primarily impacting domiciliary care in the main, feeding into the provider failure monitoring?
Yeah, so in the rule, if I go back to the regulations and the rules, we don't have a role actually in monitoring international recruitment. Uh, it's not a function that CQC has in law. We do, however, have a role in liaising with the Home Office, UKVI, and the police, where we find instances of either modern slavery. So we do and have made 4 times the referrals that we made last year. Sorry, the year before last, we made 4 times as many last year, because those have been reported to us. So we've got a role in sharing intelligence and making referrals for when we come across modern slavery. And that can come through whistleblowing or feedback on care, and it can come through inspection, I guess, when we are out and about. So we've definitely got that role. We also have a role in where a care setting has got a license for international recruitment, and we can see it's been dormant, for example. We have got a role in alerting and potentially deregistering where we come across, as it were, the abuse of the system through international recruitment. So occasionally that has happened as well. On the recent announcements, it's a bit too early to say what they mean for social care. So I recognise those are being worked on and will be announced in the spring. So I'm not quite sure we're at the stage where we can comment on those really. But provider failure as a result of international recruitment, we would treat that in a way that we would treat any failure. So if, for example, something's gone wrong with international recruitment, a license is revoked, let's say a load of nurses don't have license to practice anymore, then that would create a risk at a failure, and we as CQC would at that point intervene in the normal way we would in partnership, usually with local authorities. So we sort of treat it like every other failure issue. It's just it has that added blanket of complexity over it. I really hope that what comes out of the current national debate is clarity and consistency of approach. We did say in our state of care report, not to be political, but we did say that we still got gridlock in social care, and what movement in the gridlock there has been to do with the success of international recruitment. So I recognise it's a really, as you say, Sophie, a hot topic at the moment.
It's interesting to hear, even though you don't have a specific remit in that, there are actually a lot of things going on in the background, either to highlight abuses in the system or to individuals, or potential issues with the service of quality. So I think that must be, especially people who are supported or working in the sector, quite reassuring to hear about that. You've still got your eye on it. So thank you for sharing that. So the next subject or topic area is we have a question on partnership working. So this person is asking, with the introduction of ICBs, has James experienced any change in joint working across health and social care, for example, on NHS continuing healthcare or hospital discharge?
Yeah, so certainly ICBs are, what are they, a year old, just over a year old. And before that, though, they were STPs, Sustainability and Transformation Partnerships. So to some degree, the integration direction has been there for a while, but these new ICBs bring together partners in a different format. They've also got local government in them as an equal partner, which I think is really an important change. So the ICS is made up of the ICB, the board that runs the health service, and the Integrated Care Partnership, the local authorities that oversee places. And bringing those together in the ICSs for the first time, I think, is a really significant move. I've definitely noticed that across where we've looked in our ICS pilots, you can see the hotspots that people are working on together include discharge. They include transitions of young people from children's services to adult and health services. They also include intermediate care, so people who need to step up into short-term health services. And of course, they also include mental health and learning disability work, where there's always been quite a strong need for integrated approaches. So I've definitely seen that, and I've seen more partnership plans than ever before. Some of those are formal, like the questions suggesting on continuing healthcare or the Better Care Fund, and some of them are a bit more informal. But our ICS work, when we go to look at ICSs over the next couple of years, they will help us highlight what's good practice and what can be promoted around the place. So I'm optimistic that ICSs will make a difference, only if, though, local government stays in them, and only if they last. I mean, that's the thing about our system, isn't it? It tends to get reformed or changed. The more of that you have, the more disruptive that is to progress, usually.
So let's watch this space. In other words, hopefully some good success stories. I'm sure you'll report on them in the October report on the sector. So we're moving on to partnership working. So we've gone that one. Right. So the CQC and the sector. So this next question is, do you think that adult social care should be recognised as being vastly understaffed and under-resourced when CQC outlines its vision for improving the quality of social care? What are your views on the negative impact inspections have on staff and care services, and other criticisms such as it takes significant time and resources away from actually getting on and doing the job, and the system is potentially a crude rating system?
If you believe that things like inspections can become so overwhelming, so large and distracting that you have to spend a lot of resources on them, then you have to weigh up what's the impact of that versus doing the day job, as it were. However, I point to a couple of bits of evidence that are a contrary view. One is around the local adult social care 5 pilots that we've undertaken. So all 5 have said to us that they felt it was constructive as a process, that it was a burden to them, a new burden, but however, it enabled them to have some of the internal conversations that they needed to have about improvement that they maybe weren't having before. And also, it became a way for the directors of adult social services arguing their case for resources, alongside children's services who have their own inspection regime. So there is the view that inspection and assurance helps you paint a picture, make a case for improvement, and make a case for resources. That's the first response I'd give. The second would be that when I think about inequalities and unfairness and discrimination, really it's only by some of the work that we've done that's gone in and looked in detail at that has made a different agenda spring up. So a couple of examples of that. In the recent work around maternity, we've shown that for Black mums, their outcomes have been poorer than for white mums, essentially. And we've backed it up with evidence in terms of their treatment, the way their pain thresholds have been dealt with, the way that the outcomes have been actually for their children. So where you've got evidence like that, even though it is a bit of a burden to go in and look at that, if you don't do that, then that discrimination carries on potentially, and you're weighing up the costs of unfairness versus resources to give your your day-to-day job. And then secondly, my other example would be in learning disabilities, the new policy that we've got this up on our website about seclusion and restraint. I mean, again, this can go hidden from most of the general population's eyes, that this level of unfair seclusion and poor experience of life is going on, with people being detained and restrained and all the rest of it, which is not acceptable. So, yeah, us coming along to point out that, I think, for my heart says that's the right thing to do, even though it is a burden and people are stretched. Just because resources are short doesn't mean that CQC, as it were, can lower the standards. That's not what society wants us to do. It wants us to probably keep the standards and point out that more resources are needed. I suppose that's what we tend to think, and that's what comes out in our state of care report. But I completely recognise that as we do that, we have got to praise the good. We've got to understand the context that people are in and the stresses and strains that people are feeling. None of that goes away. So not our job, as it were, to ignore that. But we, as a regulator, can't compensate for those negatives. They are what they are. It's for society to sort of recognise it needs to prioritise and invest in health and social care appropriately.
Thank you for that. That's really helpful. And of course, there's the statutory duty for you to do what you do as well. So can't get out of it in that sense. Okay, the next question is, what does CQC feel the biggest challenges are for adult social care going forward?
Oh well. So there's a couple, aren't there? For adult social care, the issue of social care reform remains outstanding. So the 10-year plan for the reform of social care, some elements have been paused to get the fair cost of care for providers, and some elements are not progressing as fast as they need to, like the workforce plan for social care. There isn't a national approach to that, although Skills for Care is very helpfully doing some work on behalf of all of us in that space. So if we want better social care, we really have to recognise that we've got to have a workforce approach. It's got to be industry level in a way to help employers make it attractive, get people in there, pay them the right level of wages. And we've also got to have a sort of 10-year plan to change the conversation about social care, to make it less crisis and more positive. Those would be my two, actually: workforce and reform. They're still there. Actually, they were there when I was ADAS president in 2020. They were still outstanding then. We're 3 years on, and they're still needing to be done, actually.
Absolutely. And I don't think very many people would disagree with you there. So the next question is, should personal assistants be regulated?
So we don't have the power to regulate personal assistants at the moment. It's really the DHSC who would properly should answer that question. We, as it were, do as we're told once regulations have been passed. And I can definitely see both sides of this, in the sense that there's a long tradition of PAs being employed by people who are drawing on care resources and employing them. In a sense, why should the regulator come along and interfere with that freedom? On the other hand, we do receive, don't we, examples of where PA arrangements don't go so well, or the standard isn't high, and we end up with people having to take action on their own, albeit with the support of the local authority. So I definitely can see both sides of it, but in a sense, we're neutral on it until someone passes a regulation. So get out there and lobby if you've got one view or the other, I suppose I would say.
Brilliant. Thank you for that. And you kind of touched on this quite a bit earlier around how you're involving people in inspections. But this question asks, how will the patient voice and third sector be involved in inspections of integrated care boards?
Yeah, so partly we designed this in to our assurance program. So as part of that, when we looked at Dorset and recently Birmingham and Solihull, when we went to meet with the leaders in the area, we also very, very firmly met with both third sector representatives, people themselves in the community. And we did that by going through local community groups and faith groups, making sure that we were hearing from all the voices, as it were, but also doing drop-in arrangements as well for the community. So we do it in a structured way at one level. And then on to the side of that, because we're not on we don't do field work all the time, so we're only there, you know, 1 week a year, as it were, or one at a time. So aside of that, we try to make sure that we have an ongoing feedback loop. So as you probably know, CQC is arranged in 4 networks that cover the country. We have people who lead with providers and with NHS bodies in those areas. So we try to create also that feedback loop at that local level to try and get people's feedback. So we're trying to do it in a structured way. And of course, now with the SAF, we've got a place where we can record all of that, you know, in an easy way. And I guess with AI techniques, as we look at the ability of AI to draw out from our records information, it will enable us to put together the voice of people based on snippets of things that people have said here and there. You could really bring that forward into something a bit more modeled and useful, I think.
Really helpful. Thank you. Well, we've done so well. We've got through all of the pre-submitted questions. I wonder whether there have been some questions that have come in, and I will read them out. And if you feel like you would like to spend a minute or so answering any one of them, then that's fine. But if not, that's absolutely fine as well, because you've done so much. Thank you so much. So earlier on, Jav was asking, with local authorities being under significant financial pressure, what is CQC doing to support authorities? Is there an understanding that funding reducing, pressure is increasing, so quality is impacted? Domino effect. Would you like to answer that one, or should I move along?
No, that's fine. Yeah, I mean, I think it's a really interesting question. It sort of goes back to my point about, you know, just because things are stressed, we can't lower our standards. In a way, part of our job is to point out what's working and what isn't working, and what's the impact of that financial pressure. But I'll also add that as well as working with the Department of Health and Social Care, we've also worked with the Department of Local Governments and Communities, DLUC, and they and we have agreed that in the way that we report on local authorities, we'll include a statement about resources. So what resources have been deployed, what council tax has been levied, what precept has been levied. So we do try to take into account that context. And I hope that by the time we get to next October, in our state of care report, we'll be able to independently point out the consequences of financial restraint and help, as it were, build a case for investment in local government. But I completely recognise not just adults, children's services and environment services, they're all rather stretched, and we look with alarm at the numbers of local authorities who are beginning to think about their financial viability. It's not a question for us as a regulator, but we will point out the consequences to government.
Exactly. That's all you can do. Thank you. There is another question, if you have time, and that is, what is a bit more of a technical one, is CQC doing anything to reduce new providers or existing providers' interview times, as the current waiting times are very long? So I think people are just, when you have a new inspector and trying to get the interview for that, if not inspector, manager, sorry, trying to get them to have an interview so that they can start running the service and they are regulated. I don't know if you're able to answer anything to that.
I don't have much sort of practical to answer to it, really, but I do recognise it's an issue that we need to speed up, basically, to get to people as quick as we can, really. So I take the point, and I'll take it back to my colleagues as feedback.
Great. Thank you so much, James. We've whizzed through all the questions with a minute to spare. So I will let you go, and just a huge thank you for joining us today, getting through those questions and enlightening us and answering questions directly from the sector. I really, really appreciate you. So thank you so much.
Yeah, thank you. Thanks for the opportunity, Sophie, and great conversation. Cheers.
Great. Thanks. Bye-bye. So there we go. Great conversation. I hope you enjoyed it. We cantered through those questions, answered as many as the pre-submitted, and we were even very cheeky to get some of your live questions in there as well. So thank you for staying on and listening and responding to our call out for questions. Like I said, we had 300 questions. We managed to narrow those down and canter through them for this session. And just a little reminder of the thing that we have coming up next year in February. So we've got the it says Christmassy lunch, but it'll be after Christmas. Then we haven't quite changed the slide there. But in February, we'll be going through outstanding care, on a live stream like this, possibly with a panel, just to go through some of the things that we've been looking at co-produced care in terms of what has been coming out as outstanding care for care homes specifically, but also there are some dom cares in there, and just getting inspired with some of the good practice. And then I also wanted to put a shout out to anybody who wants to support the Care Workers charity. They do some fantastic work in supporting care workers who need some support, and there's many ways that you can, as an organisation or as a local authority, get involved to support the charity and the excellent work that they do. We will put in some information in the comment section, and we also will direct you on Twitter. But if you go onto their website, Care Workers Charity, and you'll find so many ways that you can support them. There, we've just put in some testimonials of what it's meant for people, care workers, to be supported by the charity. One person says, nothing to do with the process of the grant application, just to say thank you so much for the amazing work you've done. You've got me out of such a tight spot with no one else that would help. Thank you so much. So what they do at the Care Workers Charity is really, really appreciated by so many, and local authorities can help in that, as well as care providers. And we were also looking for, they're also looking for sponsors as well. So that's everything from us for now, from Co-Produced Care. I really hope you've enjoyed the session. Please do like it, because that just helps us know whether this was something that was useful for you, and you can forward this link to your team. You can watch it back, or they can watch it back at any point. The same link is the record link. And we very much hope to see you on another of our live streams after the new year. So really, it's just to say thank you so much, and have a lovely Christmas, and hopefully we'll see you all on another live stream in the new year. Take care, everyone.